Perfect. Yeah, no, I love
Awesome,
Texas. So.
awesome, awesome, awesome. All right, so we're live. Yay. Hello, everyone. Good morning, good afternoon, good evening, depending on when and where you're watching this Facebook live or YouTube live or Instagram live. This is the voice and the face of Dr. Over Benton. I'm the CEO and co-founder of Living Spring Family Medical Center here in the awesome city of Mansfield, Texas, not too far from Dallas for reference. Where we help our patients live long and well because we believe the quality of life is just as important as the quantity of life. And today we'll be having conversations on the topic, Doc, a loved one is in the ICU, help me help them. And we'll be doing that with none other than Dr. Amira Mohamed. Doc, thank you so much for being here. How are you?
I'm good. Thank you so much for having me. Thank you.
All right, awesome, awesome. Now, for those of you who are watching live, you know what to do. Hashtag live. Those of you who are watching replay, hashtag replay. And I do have a favor to ask. After the live or after the show, if there's something that resonates well with you, please put in the comments. It helps us know that what we're talking about actually added value to you and actually helps you or helps improve the quality of your life and the people you care about. Now, that being said, Doc, can you kindly introduce yourself? Who are you and what do you do?
Thank you so much. Thank you. I'd love to. So my name is Amira Mohamed. I'm an ICU doctor, and ICU stands for Intensive Care Unit. So that's where I'm primarily based. I work in the intensive care unit all the time. I work in the Bronx, New York, in Montefiore Medical Center. When I'm not in the ICU, I'm also a program director, and that means that I train the future intensivists or future ICU doctors. I am from Sudan in Africa. That's in East Africa. That's where I was raised. Even though I was born in the US. And I've completed 3 years of internal medicine training. After that, I've completed 2 years of critical care medicine training, which made me eligible or qualified to work in the intensive care unit. Finally, I'm a mother of two wonderful kids, one of whom is 5 weeks old. So that's what I do in my free time.
Whoa, whoa! Thank you for doing this. Wow, 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 wow! 5 weeks old. Congrats, by the way.
Thank you.
That's big. Now, you work in the ICU, the intensive care unit. Doc, why do you do what you do? Why do
Yeah,
you
so
do what
it's
you do?
it's a it's a completely different environment. My first experience with the ICU was actually in Sudan before I came to the US, where it's completely different. At the time, when somebody became extremely sick, we did have intensive care units. However, they were not as advanced as they are here. So essentially, being very sick meant that you were essentially going to die. Your options were extremely limited,
Mm.
and I'll be honest, I did not enjoy that part of medicine at all. But when I came to the US, that's when my perspective completely shifted. I realized that these patients did not have to die, that we did have the resources in order to not only keep them alive, but improve their quality of life. And that really sparked my interest in critical care. So since I moved here, it's been my main interest, and it's just a different feeling when you have when you're in the ICU. When I'm in the ICU, I know this patient or the patient's family, this is the toughest time of their life. They've never been this sick, or even if they have, they're extremely sick to the point where they may not be able to speak for themselves. So essentially, I was their voice and I was their only hope. It gave me a feeling of responsibility that I liked, and I felt like I was making the most impact when I was in the ICU. And that's why I started my training in critical care medicine. And this is to this day, it's where I feel like I have the most genuine conversations with people and with their families and let them know how their disease process is going, how I can help them. And it's just a wonderful feeling when you bring somebody back from that extremis.
Wow, wow, wow! That's powerful, and I love how your perspective changed. They don't have to die; they're options.
Exactly.
Um, and I'm glad we're having this conversation because I have to tell you, in conversation with some of my clients who are taking care of family members, and of course they're stressed out because of it. They feel a little helpless. So I'm glad we're having this conversation on how we can empower family members of those in the ICU to help their loved ones even during this critical time. And I'm glad that you do what you do. And with the empathy with which you do it, I can tell just in conversation with you, this is something that you're passionate about. It's a calling for you. So this is great. So Doc, my next question is, what's an ICU? For those who are wondering, I know you said what the acronym means, but what's an ICU? In layman's terms.
Yeah, so ICU stands for intensive care unit, and it's different from the rest of the hospital. Every hospital has a part of it that is considered the intensive care unit. And essentially why it's different is because the amount of attention you get, essentially. In summary, that's what it is. So it means that this person is so sick that they need a lot more attention, and therefore the ratio of doctor to patient is a lot less. The doctors who are taking care of patients in the ICU do not take care of as many patients just because their focus has to be on this patient. The nurses to patient ratio is also a lot less, meaning that that nurse has to do so much for this patient that they're not able to take care of that many. And usually the ratio is either 1 to 2 or 1 to 1, meaning the nurse, depending on how sick that patient is, can either only have one other patient or not have any other patient at all. And this kind of gives you an idea of how sick that person is, to the point where we're not able to focus on that many. We can only focus on a certain number. But it's not only the number of patients, it's also the type of patients that we have, meaning the diseases that they have. These people usually have diseases that affect an organ to the point where it has failed, meaning that we have to replace one of those organs. Some of these people need support for their hearts, support for their lungs, support for their kidneys. So depending on which organ has failed. And because of the severity of their disease, they have to be in the intensive care unit.
Okay, I'm glad that you talked about some of the the organs that are failing or failed and need support. Because some people wonder, well, why do they have them tied to tubes or attached to different equipments? Sometimes there's a concern that they look uncomfortable or they're suffering. Can you speak? Of course, you can't speak in details, but to that a little bit about the medical procedure and the equipment they're using in the ICU and why that's important. Maybe the breathing devices.
Yeah.
And the drips as well.
Yeah. So I think that's the most common thing in the ICU is people who need support for their breathing. And when we say support for their breathing, we mean we have different types, but most commonly in the ICU, it's the ventilator, which is essentially it's considered kind of the last step, because you can start with a little bit of oxygen through the nose, you can increase the amount of oxygen given through the nose, you can give some oxygen through the mouth. But if all that fails, then the person ends up on a ventilator. So a lot of our people in the ICU are on ventilators, and because they're extremely sick. The reason somebody would go on a ventilator is it can be divided into two major reasons. One reason is that their lungs are not working. They're not able to get enough oxygen into their body. So what the ventilator does is forces that oxygen into their body. The second reason is that they're completely unconscious or they're in a coma, and therefore they're not even taking breaths that are deep enough to maintain their life. And therefore the ventilator takes these breaths for them. So if somebody has lung disease, if somebody has a coma, is in a coma, or even some sort of organ has failed, they may stop breathing because of it. And essentially that ventilator keeps breathing on their for them on their behalf until they get better and until they're able to take over the breathing again. So what the ventilator is essentially it's a device that gives air that's full of oxygen, and it's connected to a tube, and the tube usually goes in the mouth. This tube is pretty long. It can be up to 20, 25 centimeters inside the body. So it can get all the way into the lungs and push the air directly inside the chest. Even though you see the tube up here, it's actually going all the way in. And this tube it's about zero point 0.7 centimeters, so 7 millimeters in size, 0.7 centimeters, so 7 millimeters in width. So it's not that big. It could be extremely uncomfortable. So I said that if somebody's in a coma and stops breathing, we put them on a ventilator. But if somebody's completely awake and they're not able to breathe appropriately because of a lung problem or whatever other sort of problem, and we put them on a ventilator, they're extremely uncomfortable having that breathing tube in their throat like that. So we have to put them in an induced coma. That's why most of our patients who are on the ventilator, they're sleeping. Either they're sleeping on their own or they're sleeping because we're giving them medication to put them to sleep because we don't want them to be uncomfortable. And I think that's something that a lot of people struggle with when they come into the ICU and to see their loved ones and they see that they're not conscious or they're not talking to them. And it can be very detrimental. Usually this is temporary, and once the lungs get better or the other organs fail gets better, we slowly wake them up. But when we first put people on ventilators, they're usually put in a coma if they're not in a coma already.
Okay, I love it. I love the balance between supporting the organs and making them comfortable at the same time too, to allow for the healing process. And as the body heals, things are weaned off. This is very good to explain to our viewers, to those who take care of those who, or who are family members of those or loved one of those in the ICU, because it gives a better perspective that you're helping them through this season where they need a little more support. I mean, a lot more support, actually. Now, next question is communication. So, sometimes in conversation with, I have to explain to them, like, oh, I try to talk to them, they will let me. I can't talk to my loved one in the ICU. There's so many restrictions on visiting hours and visitors, and I don't know why they won't just let me see my family member or my loved one. Can you speak to maybe why that is, so that there's a better understanding of why that's in place? Yeah.
So I think communication with somebody who's in the ICU, especially somebody who's on a ventilator, when you walk in, you can see them, their eyes are closed and they're not really interacting. However, the level of consciousness that we keep them at is not that deep, meaning that even though they may not respond to you and they're not obviously not able to speak because they have the tube in their mouth, most of the time these people are able to hear you. So I always encourage my patients the families to talk to my patients. So walk into the room, say who you are, tell them, what's going on in the day. Just keep the conversation going and keep interacting with them. There's a very good chance these people can hear you. And we have had patients who wake up after and say, "Oh, I heard my mom come here every day. I heard my dad say this and this to me." I remember recently I had a patient who woke up and said, "I heard my wife come in and tell me about my daughter's dance recital." So these things are important. You know what's important to that person. And so come in, talk to them every day, even if you're not seeing a response. Remember, there's a good chance that they can hear you. But not only that, touch them. I've had patients, touch their face, hold their hand, let them know that you're physically present with them. For those who cannot be physically present, we've done a lot of video calls, especially during the COVID-19 pandemic. We've done, if you can't make it in person, you can call the ICU, and I've carried iPads into the room and turned them on just to have families see their loved one and have the loved one communicate with their family in that way. So don't be shy to tell your doctors, "I want to talk to my family member," or "I won't be able to make it for the next few days because I have somewhere else to be, but I want you to provide a way for me to be able to see them and speak to them every day." And we're very happy to do that. In fact, we're encouraged, because that means that if that patient starts interacting with you, they're getting better. So
Yeah.
we really want you to try to stimulate them as much as possible. And the restrictions on visitation, it has to be a fine balance. Having family members there does get patients better. It gets them to interact. It gives them spirit in order to want to get better. But at the same time, because the ICU is where the sickest patients in the hospital are, these are the people with the most severe infections. So it's very high risk, meaning that if we have a lot of visitation, a lot of people going back and forth, it's possible that you can pick up an infection from one side of the ICU to the other, which is why there are some visitation restrictions. And these restrictions differ from a hospital to hospital. We try to extend it as much as possible. There are hospitals that allow 12-hour visitations. There's some hospitals that allow overnight visits. However, even when we do that, we usually restrict to only one or two people. And the reason is because we're worried about an infection spreading from one person to another just because of the continuous back and forth.
Awesome. Thank you for explaining that so succinctly. This is good. And I love that you say you ask, as family members ask, to be able to communicate to your loved ones, and, find out what the hours are for you to come visit. And, now that we understand why that is, we can kind of adjust like our expectations to fit what's best for our loved ones, right? So that's great. Now, my next question to you is this, though. Do you recommend any resources or support groups for families of ICU patients? And the reason I ask this question is because there's a lot of Googling that can happen, and Google is great, don't get me wrong, but an unguided Google search can be panic inducing. So are there any specific resources or support groups for families that you would recommend?
Yeah. So this is actually something that's becoming more and more popular. So we're realizing that a lot of studies more recently are showing that even after somebody gets better and leaves the ICU, they struggle to go back. There's a lot of reports of post-traumatic stress disorder from being in the intensive care, from being on the ventilator. You wake up and you're not able to speak. You feel something in your throat and you don't really understand what's happening. It could be very traumatic. So there's now a lot more support groups than there used to be, because we're understanding that this can go on even years after leaving the ICU. So right now, most of the hospitals have something called the post-ICU clinic, meaning that once you're discharged, and you go home, you're able to come back to this clinic and see providers who specifically understand the type of disease and what the process that you went through. Not saying that you should get rid of your other physicians; they're equally important. But just having that person who kind of was with you in the intensive care unit and knows what happened to you in the intensive care unit and the type of resources that you need is important. But it's not only for patients, family members too. Seeing their loved one like that, especially if their loved one does not make it, could be very traumatic. So we have a lot of support from other services. We have the palliative care service and the hospice service who reach out to patients to families that are grieving in case their family member did not make it through. For those who are struggling, we do have support groups through our community centers. So here in the Bronx, I actually give this talk to multiple community centers and some living facilities around, and just talk to them. And that's a way for them to share their experiences as well. Whenever I give these talks, there are people who come up and say, this happened to my dad, and then there's somebody else in the audience it happened to somebody else in their family, and they get to kind of connect in that way. And it's really wonderful to see, because I'm not able to understand all of the struggles that the families go through as much as I try to. So having somebody that's been through the same thing is important. So I think that reaching out to your community center is important, and seeing if they have any resources. If they don't, think about reaching out to your local hospital and asking for this service, asking for the providers to come out and speak to you about how you can handle being outside the post ICU. Reach out to your local hospital and see if they have a post ICU clinic that they can help you with if you're a patient. So they're having, combining these different resources that you have, whether it's the hospital, it's the post ICU clinic, your community center, and then the palliative and hospice services is very important.
Wow. I love the post ICU plan. And I love that there's a movement to start to increase discussions around it.
Yeah, I think we're realizing that once the person leaves the ICU, it doesn't mean our job is over. They still have to struggle and try to get back to their normal life after going through something so traumatic. So now we're kind of maintaining a relationship until they feel better and they're able to live on their own after that.
Wow, this is good. Thank you. And I love how you're teaching us and people who are watching to to ask for what they need. It could be something as simple as a suggestion, even in the hospital, if the hospital doesn't have something like this, something to look into. So this is great. Thank you so much, Doc. This has been very, very informative. I've learned a lot even listening to this. So thank you for what you.
Of course.
So my next question is for someone who's watching, are there any last minute words that you could share to them to encourage them? They have an ICU family member or patient in the ICU, or a family member or a loved one in the ICU, and they feel like they're helpless, they can't do anything, and that bothers them, and they're wondering, Doc, how can I just want to be of help to my loved one, and at this season, what last minute tips would you add before we wrap up?
I think that, I encourage families and I say that we're on the same team. We both want this person to get better. And, I'm doing the medical side and I need a lot of support from the personal side. So, important things that I ask some of the family members is, what type of music that does this person like to listen to? What is a name that I can call them? If their name is Joseph, do I call them Joe? Do they have a completely different nickname? Because I don't want to go in and be extremely formal. I want the patient, when they wake up, to see something familiar. I ask them to get photos of their families. I ask them, what should I put on the TV? Is there something they would particularly like? For example, most recently, I was told that this one patient loves watching football, and they watch football 24/7, just reruns of football. And we'd have football on all the time. And one day I walk into the room and he's awake and he's just looking at the TV, calmly watching TV. So these are the tips that I get from family members that, even though they may think they're not that important, they're actually extremely important. When I walk into the room and I call somebody by a name that they only call by in very formal situations, they're not going to feel as comfortable as when I address them in the nickname that their close family members usually use. Now they know that I know something about them. I know their family members, or there's more information that I know about them than they expect. So talk to your providers. Tell them what music to put on. How are they going to keep your loved one calm and comfortable while they're in the ICU when they're not able to speak for themselves? You are their voice. So even if you see something that you think is not important, mention it. You're not going to lose anything, and you're never going to have somebody be upset with you because you've pointed out something that they missed. So just keep that open line of communication with the providers.
Awesome. Awesome. I'm glad doctors like you exist. This is good. This
Thank
is
you.
good. So, Doc, someone who's watching is like, man, I like this doctor. I like how she explains things. I like her philosophy around the ICU. Doc, where can people find you?
I'm on Twitter. It's actually my first name, my last name, Amira Mohamed, MD. So you can find me on Twitter. Please follow me. I'll be very happy to chat with you if you send me a message.
Awesome. So we'll put that information as well here for people to connect with you. But thank you so, so much again for joining us. This has been very, very
Thank you
informative.
so much for having me. Thank you.
Oh, my pleasure. My pleasure. We'll do this again, maybe in a couple months. Okay. Maybe it's a little bigger.
Definitely. I'd love to.
All right. Thank you all for watching live and in replay. Please, as always, sharing is caring. If there are people you know that could use this encouragement in the form of this video, simply forward it to them or tag them in the comment. And as always, if you or anyone you know is looking for an awesome, a thorough, and a passionate family physicians who will have conversations like this to help you live long and well, I am she. Have a good one, everyone. Thanks again, Doc.
Thank you.